Okay, welcome to the Holistic Mike podcast. I'm Lyndsy Kinghorn. I'm a local functional medicine practitioner. Today I'm joined by Dr. AJ Burandt. He is a friend and colleague of mine, and we're going to dive into the topic of preventative cardiology, which I'm very excited about.
The sexy world of lipids.
I'd like to start the stage by actually just talking about how we connected because I think it's kind of a cool story. You want to share it?
Yeah. I would not be here without Lyndsy. So I hail from the great state of Alabama. My background is ER medicine, and I worked in Detroit and then Montgomery, Alabama. So mainly trauma critical care and a lot of chronic disease, and just got kind of burnt out on seeing the same thing over and over again and really not making headway. Got empathy fatigue, and I knew there was more. I knew there had to be more. So kind of started, I didn't even know what functional medicine was. I didn't grow up around it, didn't know what it was. A guy in my practice was a patient of a functional medicine practice. And so I became a patient there, and I had some good experiences. I had some experiences where I was like, this could be better, but I was like, there's something to this. So there's something to this. And that kind of opened my mind to what else is out there? What's out there besides what's in these four hospital walls? And so started to do some research, and then did some education. That is kind of how you and I met, through a Facebook post of, hey, I'd recently opened up a practice. If you need help opening up a practice, I'd be, willing to. And it was just a random Facebook post. And I was like, well, heck yeah, I'll take her up on this. Cause I'd been through it as a patient. I'd been through some online education and stuff, and really wanted to do my own thing because I thought that aspects of it could be done better. And then met Lyndsy, and a year and a half later, after some other fellowships and training, Plotline got created. And I probably picked the least sexy topic of lipidology to fall in love with, and preventative cardiology. And it's really become my passion now. And Lyndsy helped me start it from the ground up. I knew nothing. I mean, like, they joke that doctors make terrible business people, and we absolutely do. And she helped me avoid the landmines of creating a practice. And here we are.
Yeah, well, thank you for that. It's been a journey. And actually, we met for the first time in person yesterday,
Yep.
which is amazing. We've been colleagues over the last year and a half, so it's fun to meet in person. I am interested during kind of that, that phase where we were working on your business and kind of deciding what your niche was. What made you decide like preventative cardiology, lipidology?
Yeah, I think the short version of that is, being in the ER, we like instant results. We like to make a difference. We like to feel our difference. We like to see like what we're doing is actually working. And so going through chronic medical conditions and how you can really make a difference is ASCVD, or heart disease and strokes, is the number one killer worldwide and number one killer in the United States. So I was like, well, that's a good place to start. If we can figure this out, that would be rewarding. And so really delve into it and found like, wow, there's an area of opportunity here that we can actually, like, this shouldn't even be on the top 10 list of things people die from. We have medications to treat it. We have alternative therapies to treat it. We can diagnose it early. There's a bunch of cool stuff going on in the field. There's tons of research into it. And I just fell in love with it because felt like I could make a huge difference with it. And I live in Alabama, which is not a healthy state. So I knew I would not be lacking patience.
Yes.
And researched around me, and really nobody was doing this. And I come from terrible cardiac genetics in my family, so I was worried about it at an early age, and just went on from there.
That's amazing. I know my background actually is emergency medicine too before I found functional medicine. And I view things totally different now, like health in general. But I'm interested to see how like you view cardiology, just cardiac health in general from like being an ER physician to now, how that's changed.
Yeah. If I see you in the ER for heart stuff, it's usually not pretty and it's not good. It's usually from a heart attack or decompensated heart failure. And people just don't do well with those things. So, like, an interesting statistic is about half of people, their first symptom of heart disease is showing up with a heart attack. They have no warning signs, nothing before then. They show up in the ER with a heart attack and go get a stent. That's their first indication of having a heart problem at all. And so when I see you in the ER, you're so far down the pathway of something that could have completely been prevented.
Mhm.
And so I see it now of, I see these people who literally come in once a month for decompensated heart failure after having a massive heart attack. And it's just like they're a regular. I know them, I know their family, and I know the cycle. And it's just not a awesome life for the patient. And it's really frustrating from an ER perspective because it could have been prevented and just wasn't prevented. And so I think it made me want to just have people not ever have to see me in the ER for
Yeah.
heart stuff.
So the preventative side as opposed to the reactionary, like what can
Totally.
we do foundationally, lifestyle, even with conventional medicine to keep these people out of the ER?
Totally. Yeah. If I was out of a job in the ER, it would be a great day.
Yes,
Like,
yes.
that'd be awesome. I think our system's good at acute care. It's terrible at preventative care. I think we've proven that since, well, ASCVD is the number one killer still and shouldn't be.
Yes.
So,
Well,
room for improvement.
absolutely. Thanks for sharing that. I want to talk more about cholesterol.
Oh, yeah.
The good, the bad, the ugly. Um, we have, previously just been like a lipid panel and this is it. This is your risk. Yes or no. Do you want to get into cholesterol? Talk more about
That's why
cholesterol?
I'm here. That's
I
why I
know. Let's
flew
talk about it.
2,000 miles. Yes. So, cholesterol is what we found to be the most important thing driving ASCVD and plaque formation and heart attacks. So in the past, we've always thought as, we've had cholesterol, we've had smoking, we've had blood pressure, we've had diabetes. All of these are super important. But what we were finding was we get all these metrics and be meeting all these goals by all these societies, and our patients were still having events.
Mhm.
So we're like, what are we missing? We're missing something. There's got to be residual risk somewhere. Like, these people should not be having events, but they are. And so there's been so much research into this. And what's awesome about this is we can really simplify lipidology and preventative cardiology now and make it easy and accessible for practitioners and patients. And that's something called ApoB. So cholesterol, just for nomenclature, you go into your doctor's office and a lot of times the term good cholesterol or bad cholesterol is used. And it's poor nomenclature. Cholesterol is cholesterol. There's no difference in cholesterol. What's different is what's called lipoproteins that carry cholesterol around in your blood. If you think of blood as water, cholesterol is fat, those two things don't mix. And so you need some way for your body to carry around cholesterol inside of that blood. So it creates what's called lipoproteins. And that's what, when you hear the word LDL or HDL, those are lipoproteins. And traditionally, people say bad cholesterol is LDL, good cholesterol is HDL. The cholesterol is the same. What's different is the lipoprotein. And the traditional thought was HDL is good because it takes cholesterol out of your artery walls, brings it back to your liver, and you poop it out. Theoretically, that's a good thing. That should make your risk lower. And then LDL is quote unquote bad cholesterol because it's putting cholesterol into your artery walls, which creates the narrowing, and then you have heart attacks and strokes from it. Um, it's a lot more complicated than that, but it's come down to something called ApoB. And ApoB, what it is it represents every bad particle of atherogenic cholesterol in your body. And what it does is it gives us, in medicine, we need to keep things simple. Like, if you make it complicated, that's when things start to get screwed up and things get missed. Is now when we measure this thing called ApoB, which is a lipoprotein, the thing that carries around cholesterol, the ApoB represents every single bad particle of that in your body. And we know that lower is better, treating earlier is better, and treating for longer is better. And we know that ApoB, this is a huge statement, elevated LDL cholesterol and ApoB are causative of ASCVD, meaning this X causes Y. And when you have that and you understand the variables to that equation, now you can solve the problem, right? So it's been proven over and over again that ApoB is what causes ASCVD. And now we get to attack that in very fun ways.
Yes.
So that's a very brief overview of lipidology, if you will, and preventative cardiology.
So ApoB is the player. Like that's what we need to be worried about.
ApoB is the player.
And is that accessible for all of us to order or
Absolutely.
a patient to grab?
So it costs about the same amount of money as your standard lipid profile. And you can get it from anywhere. Your primary care doctor can order it. It's not a fancy test that needs insurance prior authorization. ApoB is very accessible. I think it's like $10, $5, $10. And I get that in congruence with a couple of other labs. But that is the number that matters. That's the number that when we get lower and there's different patient populations, that we want that number to be at a specific threshold. And when we get that, we can say, hey, we are either hopefully preventing ASCVD or we're getting it to where you're not going to have another event.
For sure.
Yeah.
Beyond lipid panels, what are like screening tests that either patients or clinicians should be aware of that are on the market?
Yeah. So I kind of explain it to my patients in three different layers, if you will, as far as cardiac prevention goes. A lot of ASCVD, about 80% is estimated to be genetic. Mm-hmm. So lifestyle is very important for everybody, but ASCVD is one of those caveats where your genes matter, like big time. Mm-hmm. And so with all my patients, I start off with specifically an ASCVD genetic panel. And what that is, it's just a cheek swab. It's genetic, so you only have to have it tested once in your life. And that tells us this is medical genetics. This isn't like checking, where your ethnicity is from. This is like saying, hey, your cholesterol is high, but it's high because you have an LDL receptor mutation that's causing it to be high. Or you have a genetic mutation to cause this to be high. Or you have a genetic disposition for early onset ASCVD or Alzheimer's. And it gives us targets to know what you're genetically susceptible to. And once I have your genetic layer down, then we start to get into your, biomarkers, people will call them, lab work, whatever you want to call it. Things like ApoB or LP(a), cholesterol panels, thyroid panels. So we then have your genetic component, then we have your cellular component, and then on top of that, in certain patients, we have an imaging component. Mm-hmm. And with tests nowadays, we can get so accurate with our CT scans that give us 3D pictures of your blood vessels. And if there's early worrisome plaque or late plaque that's been there a while, we can see exactly how much, where it is. And when you combine all three of those layers, I now have a great idea of your risk or current disease that you already have and what we need to do to treat it. And if we're treating it appropriately.
When you say, because I know there's clinicians that listen to this podcast, but they'll be like just lay people as well. What do you mean by plaque? Can you describe what plaque is?
Yeah, so plaque is the buildup of cholesterol in your artery walls. So what happens is this is called atherosclerosis.
It's a word. Atherosclerosis.
That's why I say plaque. Is what it is the buildup of cholesterol in your artery walls. And over time, this is a disease that happens over decades. It doesn't happen over a month. It doesn't happen over a year. This happens over a lifetime. Mm-hmm. And what happens is you have cholesterol being deposited in artery walls where it shouldn't be deposited. And over time, that starts to narrow your artery. And when it gets to a critical narrowing where it ruptures, you either have an MI, you have a stroke, and you can have a vent. Mm-hmm. So when I say plaque, it's cholesterol where it should not be in specifically your artery walls.
And when you say MI, you mean heart attack?
Yeah.
In terms of the imaging, which you talked about, I think you were alluding to the Clearly, which is awesome. What would make you want to do like a coronary artery calcium score over a Clearly or vice versa?
Yeah. So we'll start with we'll work our way up in fanciness, if you will. Yeah. So a CAC or a CAC or calcium score is you go and get a CAT scan, and you don't need contrast, you don't get an IV, and what they're doing is they're taking pictures of your coronary arteries, and that's the blood vessels that supply blood to the heart itself. Mm-hmm. The heart is a muscle, and it needs its own blood supply. So what that's measuring is calcified plaque in your coronary arteries. And what we know, though, is, like I just said, is ASCVD is not a disease over a day or a month. It's over decades. And calcium is the end result of plaque that's been there for at least a decade. So you're kind of getting the end picture of the plaque. And these are not the lesions that are causing acute heart attacks. Mm-hmm. The lesions that are causing acute heart attacks are what's called soft or lipid-rich necrotic plaques that are earlier in their phase, in the first year, in the first 5 years. And the CAC or the calcium score misses those. Mm-hmm. So, or in young people, they're not useful because a young person hasn't been around long enough to have calcified plaque. And so a calcium score it's useful in some certain circumstances. The nice thing is you don't need contrast, and it's pretty cheap. Some places are $100, $200, so it's pretty accessible. But it's limited in young patients because if they have a calcium score of 0, that tells me nothing if they're going to have early plaque. And if anything, they probably have early plaque. And also, when you get this and you have a high calcium score, that's been there a long time. We've already missed our prevention window. So work your way up from that. Then you have what's called a CCTA, or a coronary CT angiogram, where they do the same CT scan, but they put an IV in you and then they inject contrast dye. And these are technically hard studies to get because if you think about it, your heart is a beating organ. And then in between the beats, the CAT scanner has to obtain pictures of blood vessels that are only a few millimeters wide. And we're looking for very narrowing or very small areas of plaque. So what happens with this versus the calcium score is now we get to see inside the blood vessel walls, and we'll see if there's any narrowing there from, we can pick up some soft plaques on this, and then we can also pick up the calcified plaques, and then we get an idea of how much narrowing. So, in the traditional world, just to oversimplify it, if anything has 70% stenosis or more, you're usually going to get a stent. 50 to 70 is a kind of gray zone and depends. So it gives us a better overall picture. So that's a CCTA. And then nowadays, to talk about all the cool stuff, is you have a CCTA now, which is that same test I just talked about, but then you can upload those images to an artificial intelligence software program. And the one that I use is called Clearly. So the artificial intelligence software program looks at those pictures, and then it gives us a printout of the coronary vasculature. So I get a 3D printout of your blood vessels, and then it quantifies it, and it will tell me and label, color code it, make it very easy, that this is a calcified plaque that's been here a long time. This is one of those really bad, lipid-rich, soft plaques in a very bad spot. We need to worry about this. So it tells me now with very incredible accuracy where the plaque is, what it's composed of. Is it one that we're worried about rupture? Is it a stable plaque? Is it something that might not need a stent? Is it something that does need a stent? So it really adds, instead of having to go through the traditional model of EKG, stress tests, nuclear stress tests, cath lab, maybe a stent or not, you can get so much more information early on, especially from young patients. Right. So I use that in a lot of my patients, and it gives me, I can't, it's probably the biggest thing in my practice and actually in medicine that I've seen in the last, I'd say 10 years of I catch patients all the time with asymptomatic disease that can be intervened on before they have the heart attack. And it's been just last week, I had a patient who ended up going to get a cardiac cath and a stent who had no idea he had cardiac disease. No idea.
That's the scary part, right? The heart disease is asymptomatic until they're having an event. When would you recommend people start screening? Like, I know there is, like, I would just say average. I know it depends on life, like family history and whatnot,
Yeah.
but would you say average would be a good time to start at least blood screening
Yeah.
labs?
That's a really good question. So actually, the American Academy of Pediatrics came out and they recommend a screening lipid panel by the age of 8 or 9. So you're talking very early age.
Is that basic lipid panel or ApoB? Is that advanced there yet?
Their guidelines is basic lipid panel. I think in the next handful of years, all your guidelines now are going to start to include ApoB. But so you start cholesterol screening at a very young age now, 8 or 9. And then above that, you start to get into, do you have anything genetic like something called FH, familial hypercholesterolemia, that puts somebody at risk at a much earlier age of having a heart attack, or something called lipoprotein little a. If you have a marathon runner who seemingly looks healthy and drops dead of heart attack at 35 years old, that's probably what they have. So in certain subset of people, you're going to start screening at a super young age, maybe even treatment at a super young age. And then the guidelines for getting imaging, things like Clearly and stuff. There's no established guideline for this. Technology is so new. But in my practice, I would love if by the age of 45, everybody had a screening CCTA. And in some people, if you're genetically predisposed or have bad genes, I think even earlier. I'll use me as an example. Most of the men in my family have had heart attacks, stents, bypass, and at 50s, 60s, so pretty early.
Mm-hmm.
And so I knew right away that I was at a lot of this is genetic. So I knew before I even tested my genes, I was at higher risk. So I actually did a Clearly study when I was 34 years old. And on my scan, I have a 7% soft plaque in my proximal LAD. That's if you've heard the Widowmaker. That's a big blood vessel that supplies a lot of the heart. And it's called the Widowmaker because if you have a heart attack in that blood vessel, a lot of times you don't survive it, unfortunately. And so what that indicates to me is at a young age, by any traditional risk scores, I wouldn't have been put on treatment. I wouldn't have thought twice about it. My numbers were pretty good, but they weren't bad enough to require treatment. Is now at the age of 34 at the time, I have a 7% lesion that's not clinically causing any issues, certainly doesn't need a stent, but now I have the opportunity to make sure that 7% lesion doesn't turn to 8, doesn't turn to 20, doesn't turn to 50, maybe it even goes down a little bit. And so my goals now in treatment are much different than if I didn't have that piece of information. So it's my goal in life. Like I'm not dying of a heart attack or a stroke.
It's the prevention, right? That I think gets overlooked, especially in the cardiovascular space. And as you said, it kills more than, I don't know if we said that on the podcast, but we were talking this morning, just like the statistics of how much heart disease kills as opposed to other diseases.
Yeah, it kills more than the top 10 cancers combined. Every 1.7 seconds, somebody dies from heart disease. And a third of people in this world will die from a complication of ASCVD. So one of us in this room right now will die of a heart attack or stroke or some sequela of plaque.
It's wild.
Yeah, and it shouldn't be.
Yes. In terms of so there's a lot of holistic practitioners that can encompass massage therapists or acupuncturists, a lot of different modalities that listen. What are some actual things either they can help their patients with in educating them, or even patients could make shifts in life to move the needle in their risk?
Yeah. So I think that in this realm, knowledge is power. So finding things out early, if you already have disease, what you're predisposed to, I think that's the foundation of making any decision.
Sure.
And we can get so nitty gritty into it of knowing kind of people from a genetic standpoint of, hey, your diet is going to make a much bigger impact. Obviously, diet's important for every single person in this world, but we might be able to make a much more significant impact in you because of this specific mutation with diet, or this specific medication for you due to this specific circumstance. Or the best thing in my practice I love is when I get to de-escalate care, or get people off of things or off of stuff. I think it's the great thing about ASCVD is we have so many tools in our toolbox, so many that if you don't tolerate one thing, we have 4 more other things. Or there's just, if you're not comfortable with one, we can do another thing. And so I think I'm always leery of practices where it's just like everything's a nail and they're the hammer and they do the same thing over and over. Everybody's truly an individual. And I think it all starts with the foundation of gathering the knowledge and then piecemealing what would work for that patient. Because there's certain patients that, like, I'd be doing them a disservice if I just said, go clean up your lifestyle and that's it. Like, there's certain people that need more than that. Then there's certain people that might be on meds that don't need to be on meds, that they could just do lifestyle modifications. Right. So
very personalized, individualized medicine is how it should be.
Yeah.
In terms of diet's kind of hot. We won't go into the weeds on diet, but I know this is also very personalized, individualized. Is there a specific diet that you recommend to most of your patients that could be beneficial?
Yeah. So I'll talk about the subset of patients with heart disease. Let's say, we've done your workup, done your scan, and you either have heart disease, had a previous stent, or have, some good plaque buildup. This is very well studied. Super important things, it's very easy to remember, is low saturated fat intake. That's a big deal. That's more important than dietary cholesterol when you're looking at a label. Saturated fat, decrease it. So saturated fat is any fat that's a solid at room temp. So like butter, large, stuff like that. And then as far as like an overall diet style goes, Mediterranean diet has been proven time and time again with very robust medical trials to decrease major adverse cardiac events, or MACE. And the foundations of that is low saturated fat, good lean proteins, fish high in natural omegas, anti-inflammatory. So I really harp on that for my patients that have established ASCVD.
And with the kind of hot diet of carnivore, do you have a thought around that?
Yeah, I do. um, so like when a patient comes to me and they're dead set on like carnivore, keto, or anything like that, we know about 20% of the population are what we call hyperabsorbers. So they are genetically predisposed to absorbing more cholesterol from the environment than somebody who doesn't have that. So when you do a ketogenic diet or a carnivore diet, by definition, those are extremely high in saturated fat. So when you take somebody that has a great lipid profile, their LDL might be like 55, looks awesome, and they do a ketogenic diet, you could repeat it and their labs are like an LDL 350, which is shockingly high just from diet. So the question is does that matter? Like, or is it, I feel so much better on keto, am I okay to tolerate these high lipids? And the answer is no. They've actually done studies in young, healthy individuals when they do get their cholesterol that high up from diet, is they start to form plaque. And so there's absolutely individuals who will feel better on a specific diet. It might be treating something else specific, like in the gut, that you're doing a ketogenic diet for a very specific reason. Is we have two options. We can change the diet, or we have to treat the lipids. And if that diet is really working for other parts of their lifestyle and they don't want to give up that diet, that's okay. Just let me treat your lipids. So from a standpoint, it's to a point too where people ask me recommendations. Now I can kind of give them a recommendation of, I would not do that. Yeah. Or I think it'd be okay in you. We just have to watch your lipid parameters. Because some people might not react that dramatically to it. So
as always, individualized.
Individualized.
Right? So it's all about your genetics, your own risk factors, and other risk factors.
Yeah, my appointments take 1 to 2 hours on average. That's how important time is. And I think the most important thing that we could ever do as clinicians, no matter what space you're in, is truly educate your patient on what's going on with them from a physiologic standpoint, so they understand it. And the disease process at a nitty gritty level, and then to present to them all the different treatment options, A, B, C, and D, the pluses and minuses of each, and then to let them decide what do they feel comfortable with. And sometimes they ask me, they're like, well, if you were me, what would you do? But I think that's the most important thing, is just to give them true researched information that they can hang their hat on and then make a decision on what they're comfortable with.
Yeah, like informed consent. They get to make the decision if they're
100%.
well educated and versed on that. What would you like to send the gosh, I'm gonna say this. What would you like the listeners to take away from this podcast?
Yeah.
Top 3 things.
Okay. Get screened early and be an advocate for yourself in this system. So stay up to date on this stuff, and nobody's going to be a better advocate than yourself. So take your family history seriously. Take your risk of heart disease seriously, and ask your doctor to screen for these things. Specifically would be LP little a and ApoB. If I were to go to my yearly labs, I would ask for, we'll just keep it real simple now. Screen for those two things. Ask for that blood draw. And if they don't do it, find somebody who does.
I was going to say, find somebody else if they won't.
Yep. It's that important. And then the next thing would be to find somebody that will go along with you during this journey and through this journey. Because there's so many platforms out there right now that are direct to consumer, where you go online and you buy a $500 panel of, awesome lab tests, but then like, what do you do with them? how do you interpret that? And it causes a lot of anxiety, or can cause a lot of anxiety. And how do you work through that? What actually matters? Shoot, am I getting Alzheimer's now since this test tells me I'm at risk for it? You need somebody to um, really walk you through it, that knows it, that will take the time with you. You know, if you go into an office and are rushed at a visit during 2 minutes, that's not your person.
Right.
Like, find somebody else. There's people out there that are great practitioners. That it takes time to. There's no more beautiful thing on this planet or creation on this planet than the human body. Like,
Yeah.
it takes so much time to understand that, and somebody with that expertise. And so find somebody that fits or aligns with what you're trying to do in that space. And then three, you know, since we're talking about heart disease, take it seriously. And be very careful where you get your information from. There's a lot of bad information out there. And take your lab seriously, take your genetic risk seriously, take your family history seriously. And before you make judgments on treatments or not, or drugs or not, if they're good or bad or not, have an informed decision with somebody who actually knows what they're talking about, not just a TikTok reel that you saw that says X, Y, and Z is bad. So really take your health into, you know, we get one life. Like, you gotta like take it seriously.
So true. I talk about that often with patients. Like, it's awesome how much, exposure or information is at our fingertips, but also that's a detriment to some too,
Totally.
because it causes so much into anxiety. So I love that. So screen early.
Yep.
And if somebody won't screen you, find somebody else to screen you.
Yep.
Find a partner in health.
Yep.
And then take it seriously. I think that's great.
Yep.
Well, thanks for coming on today. It's been great to have you.
Thank you. Well, this has been a pleasure. I'll talk lipids any day.
I love it.